Hello, everyone, and welcome to Death Talk Unscripted. I'm a death walker. My name is Paula, and I'm your host. Thank you so much for joining me. Have a seat. This is where we talk about death in a raw, honest, and very clarifying manner. So, tonight's episode is what I have come to call the war on care. It is, from my perspective, a clinical examination of how the opioid policy in this country is harming the elderly, the chronically ill, and the most vulnerable of our society, which is the dying. So, I was told that this was, when I had someone read it, they said, an evidence-based indictment of a system that fears addiction more than it fears suffering. And I absolutely believe that is head on, dead right. And I'm glad that they got that particular deal from reading this paper that I had put together. So I think one of the things that we should talk about, first of all, is when policy, any policy, but I'm going to be talking about the opiate policy in this one, becomes a form of punishment. The United States, which, if anybody's been around long enough, you have heard, oh, the war on drugs, we're winning. Well, I'm here to tell you that the United States did not solve the opioid crisis or end the war on drugs. It was just redirected. It was redirected into fear-mongering, and it was also redirected towards the wrong bodies in society. Today, the elderly, the chronically ill, and the dying, they're treated as if they're responsible for the addiction epidemic, as if their legitimate need for pain, relief, sleep, comfort is somehow dangerous to the public. This is something that we have been fed. This is something that we have been led to believe to be some significant truth when it's exactly quite the opposite. The result, therefore, is a system where end-of-life suffering is not only common, but structurally enforced. So what I'm going to be presenting today is going to examine clinically and directly how the opiate era policies have created severe suffering, sleep deprivation, untreated pain, increased suicide risk, and a systematic cruelty at the end of life that just shows the complete lack of humanity that we are currently experiencing as a species. This is not an opinion. This is evidence that I'm going to be discussing. Severe suffering at the end of life. Can you imagine? Imagine your life and imagine just for 1 minute how it would be in that last context of time to be suffering. So this is a clinical definition that we honestly keep ignoring. I'm going to start off in palliative medicine. Severe suffering is a clinical threshold. It's not a metaphor. It includes pain, insomnia, agitation, breathlessness, anxiety, delirium, and any symptom that significantly impairs a person's ability to function or to rest. I'm sure we've all experienced where we haven't been able to sleep and it's gone on for 1 night, 2 nights, and the longer it goes on, the longer we're that sleep deprived, it really affects us physically. Now imagine that physicalness on top of chronic illness, on top of end-of-life cancers, on top of MS. So it really is comes full circle. It really lets you realize that everything is connected. Sleep deprivation is one of the most clinically severe symptoms of a dying person. And not only that, it's one of the most severe symptoms that they can experience. There's some Harvard research that shows that 24 hours without sleep impairs the cognition to the level of a blood alcohol concentration of 0.10%. That's legally drunk. 2 to 3 nights without sleep produce cognitive failure, emotional instability, depression, and inability to perform basic tasks. Now think about that. This is all occurring in the elderly, in the chronically ill, and even in the dying. And we're saying, okay, maybe we'll do something. Maybe we won't. And for me, I think it's all about, where's the humanity? Where's the empathy? Where's the compassion? For a dying person, this is not discomfort. It is clinical harm. Everybody spouts, do no harm, do no harm. Well, harm is being done right in front of us. Right and at the most vulnerable time in a human being's life, or at least the very last vulnerable time. Yes, and here's the thing. The sleep medications are routinely withheld due to an opioid-era fear of respiratory depression. These people are going to die. They're going to have respiratory depression. It's going to, their lungs are going to stop beating anyways. They're going to stop breathing. The heart's going to stop beating. So this respiratory depression it's just an oxymoron in so many ways. Even when the patient is already in the final stages of life. I mean, when you are down to the last week of life, really? We're going to worry about respiratory depression, but we're going to let them feel we're going to let them feel all that discomfort that they were feeling? We're going to make them suffer? And the refusal to treat insomnia at the end of life is not evidence-based care. It's a policy-driven cruelty is what it is. It's a systematic, it's one more of the symptoms of a systematically broken healthcare, any type of end-of-life care. It's just broken. One of the things, I'm going to stay with sleep deprivation for a little bit, and I'm going to talk about that in terminal illnesses now. And it is a documented medical harm to do this, by the way. So any one of you out there who are caregivers, who are family members, who are actively working in the moment with your loved one in a hospice type situation or an end-of-life situation, then I absolutely want you to document everything that you possibly can, because sleep deprivation is not a benign symptom in terminal illness. Marie Curie's palliative research, I believe, confirms that insomnia worsens pain, it creates anxiety, depression, and physical symptoms. This is not something that a terminal illness person should have to endure on top of what is already happening for their life to be ending. Do you see how it's just cruel to extend these kind of things? It reduces the ability to cope with the illness and increases the distress to both the patient and the caregiver and the family, because they are led to believe that they are failing their loved one. They are not doing enough. They are still witnessing the agitation, the anxiety, the pain. And all that goes through their mind is, what have I done wrong? What have we done wrong? Despite this, sleep medications, they're often denied to dying patients. Not because they're unsafe, but because clinicians fear regulatory scrutiny. And that's the other side of the coin. Most of the people that I know in the death working industry, the end of life, the hospice, palliative care units, they are all kind, for the most part, the ones that I have met, 90% of them have all been kind, caring human beings that have been traumatized by a system that no longer allows them to use their calling in a healing and loving way. One of the things that I'm going to go over right now is the prescribing process itself. For these professionals to prescribe the sleeping medicine, they put the biggest barrier in front of it and said, okay, do your best. Physicians must justify every sedative. They must document every risk and anticipate every potential accusation of hastening death. This is what we're worried about. This is the stress we're putting on these doctors, rather than letting them go out and be kind, compassionate, and helpful at the end of life for people who are terminally ill. A lot of the clinicians admit privately, they were talking to me, and I also sat in a group Zoom meeting about this, and they privately admitted that they avoid prescribing sleep medications because the regulatory burden is too heavy and the professional risk is too high. So they're being blackmailed and bullied into not. Think about that. They're being blackmailed and bullied into causing harm for the dying. They are being blackmailed to withhold the proper care, the proper medications. So if you're listening right now, yes, this sounds ludicrous. It sounds crazy. But more importantly, it sounds downright inhumane. And so there is also the denial of sleep at the end of life. It's not a medicine. It is fear masquerading as caution. And if you ask a dying person, would you rather have fear masquerading as a caution and caution beware and ew, or do you want the damn sleep pill so that you can go to sleep? And it's okay if you don't wake up, by the way. I'm okay if I don't wake up. I'm on my way out anyways. It's not like I was going to recover and jump up and say, woohoo, I'm back alive again. So anyways, got a little over the top on this one, but that's just the insanity level that we are at. It is such a illogical time. Everything is illogical, backwards, out of alignment, way out of tune. And so that's kind of what brought this article about, because every place I would go, I kept seeing this happen and that happen. And I heard some woman, I was in a nursing facility, and one of my clients, we went to see her mother, and we were passing this room, and this hospice person, I'm assuming it was a person who worked at the nursing center. Apparently their family had said something about making their family member more comfortable. And this woman said, we are not in the business of making 84-year-old women drug addicts. And of course, if I had been really paying attention, I would have gotten her name. I did end up reporting her to the agency, but this is where we are. This is what's going to be, this is what's happening. So We're going to move into what the opiate restrictions are in hospice. What does this equal? This equals the collapse of comfort care. These restrictions have literally just about collapsed our comfort care that we use. Hospice care relies on opiates for pain, for breathlessness, for cough, for anxiety, and for what is also known as terminal agitation. These medications, they're not optional. They are fundamental to comfort care. Yet research shows widespread medication shortages, reduced opioid prescribing, stigma, and a huge undertreatment of pain. Diversion policies treat families like suspects now, and clinicians, they're potential criminals. You give them a pad and a pen and they'll corrupt. They'll start whipping out those opiates left and right. Pretty soon, every elderly person, every terminally person will be an addict, and then we're going to have to contend with addicts. And it goes round and round in absolutely insanity. Anyways, the Hospice and the Palliative Nurses Association, and I believe it's the American Society for Pain Management Nursing, they warned, they have been warning that opiate crisis policies have seriously compromised pain care at the end of life. So these organizations, they've been following this, and they have been keeping data and tracking what's going on. And they specifically say seriously compromised. How sad is that? The opioid war has invaded hospice. I'm saying that again. The opioid war has invaded hospice. A space designed to prioritize comfort over cure. Instead of easing suffering, the system now polices it. Doctors and nurses who once saw their work as a calling now fear retribution, investigation, and some of them professional ruin. I know several doctors who are in jail serving time because they gave them not the generic morphine, but the good morphine to a patient that was 94 years old and had breast cancer and brain cancer. And he's sitting in jail. The other thing is, instead of easing the suffering, the system now polices it, like I said. And the opioid war has not only harmed the patients, it has damaged the moral and clinical integrity of the professionals who care for them. It has really torn it apart. How can you trust someone? How can you think that these people have integrity when they allow this much suffering? One of the funny things is, and this is the next part that I'm going to be talking about, and it's the DEA, the Drug Enforcement Agency. Talk about Big Brother in being so far over the line, so far reaching, that they honestly think that they should own the bodies, and in owning the bodies, be able to dictate how each body's going to die, whether it's going to suffer. Can you imagine the arrogance of that? And we just handed it over and said, here you go. Do it. We don't want to mess with it. Well, they did. So the DEA diversion policies, this is when, the first one I said was when when the wrong people are being punished. This one says when regulations become punishment. The DE diversion policies require locked medicine boxes, strict pill counts, disposal monitoring, surveillance of caregivers, and a documentation of every dose. Now imagine the caregiver has spent probably months, if not years, doing this situation, taking care of their loved one, doing everything in their power to make their loved one die with dignity and honor, and hospice is the only way to go in this particular state. That's the one out. And you don't even get the full benefit of it. You're going to give them knockoff drugs. You're going to make the caregivers and the family members feel like you're going to make them feel like they're criminals, like they've done something wrong. You're going to show up as some sort of law enforcement and be demanding and rude, and this is all going to be okay for the dying person? You really think that's going to leave energy that's going to bring a good death to anybody? So these policies were designed to prevent misuse. Yes, we understand that. But in hospice, they create delays in medication access. They fear of doing it wrong. There's emotional distress, and there's distrust between clinicians and families. And and that's a very sad thing, because it's the dying person's very last moments. And you have the families pitted against the clinicians, and the clinicians pitted against the families. And all of a sudden, there is a disconnect. There is dissension even. I'm sorry, I'm just getting over a cold. Nurses are forced into policing roles. Can you imagine? And caregivers, who are the backbone, I'm a caregiver, and we are the backbone of the end-of-life care. And now we're being treated as potential thieves? Come on, get a grip. So this is a perfect example, like I was saying before, of government overreach, a system that asserts control over the bodies of the dying until their final breath. Even when pain is severe, even when sleep is impossible, even when suffering is evident, the response is often, "We're sorry, there's a shortage," or "We're sorry, we can't prescribe that. Would you like us to rub your elbow?" I mean, regulation has replaced compassion, and compliance has replaced care. That sigh was just a sigh, just realizing where we are and what it is, and what, it is what it is kind of deal. So I'm going to talk a little bit about fentanyl. Fentanyl enforcement versus medical access. Now, this is a national contradiction. Illicit fentanyl floods American streets. And by that I mean the DEA allows this because when they flood the streets with the illicit fentanyl, their logic behind that is they are tracking larger networks. You with me on that? So they lay the drugs, the illicit fentanyl, back out on the streets in hopes to catch a bigger fish. However, here we go. When it comes to medical fentanyl, regulated, safe, and essential for severe pain, it's restricted, monitored, and often denied to the elderly, the chronically ill, and the dying. This contradiction is not medical. It is political. So you're going to have the illicit fentanyl all over the streets. And then the medical fentanyl, you're not going to dose out? You're going to hoard that and keep... So here's a little thing that I would say. It's going to be really raw, so get ready for it. All of us better go out and find a drug dealer to get the good shit. That's it in a nutshell. You should put that in your death plan. Because the way this is going right now, you would get way better stuff, and it would be way less restrictive. The same. So pharmacies report shortages of hydromorphone, fentanyl patches, and even basic comfort medications used in terminal care. And, the streets, like I said, they're just saturated with opiates, all kinds of opiates, Oxycontin, I'm just speaking of a couple here in this deal. Hospice kids, they often lack morphine. Well, can you imagine? So, and the same supply chain that allows illicit fentanyl to circulate freely cannot reliably produce morphine for dying patients. Shall I say that again? The same manufacturing system that floods the streets with counterfeit pills cannot produce enough sleep medication for people who need rest to survive their final days. This is not a supply problem. This is a priority problem. Here's something that very few people will talk about. When it comes to end of life, in chronic pain or untreated pain, or even in some case, dying patients who absolutely do not want to go through hospice, period. So it leads to a suicide risk. And the suicide risk is in chronic illness, untreated pain, and in the dying elderly population. Untreated pain and sleep deprivation increase despair, depression, and suicide ideation. Research shows too that sleep deprivation worsens depression and anxiety if they're already in it. Caregivers experience psychological distress and increased mortality. And terminally ill patients with uncontrolled symptoms experience illness or terminal diagnosis. Suicide is not chosen out of impulsivity, but out of the rational assessment. The suffering is unbearable, the symptoms are untreated, and the system refuses relief. When those three are combined together, you and I both know that suicide will be the end result from that. Here's the thing about that, though. These deaths are not counted. They are not tracked. They are not acknowledged in any national database. So if you wanted to find out, you couldn't. Yet, they are a direct outcomes of a policy-driven suffering. A humane society would record these deaths, analyze them, and respond to them. Instead, we hide them behind the rhetoric of preventing addiction. There's a really cool little infomercial in there somewhere, I'm freaking sure. Our system will proudly say, we didn't let them become addicts. Hoorah! Hoorah! One thing our society will never say is, we let them suffer. So I've kind of gone over a few simple things of the opioids and the fentanyl and the sleep deprivation, and I've talked a little bit about the federal government and how it overlaps into the system. It's all a war on care. That's what it is. Anybody who needs care. Back surgeries aren't getting pain medicines. They tell you to walk out with a Tylenol. Hip replacements now are given with a nerve blocker that may or may not. There are so many side effects to that nerve blocker on a permanent basis. And then told to be given Advil or Tylenol or whatever it is. It's everywhere, It's everywhere, people. I do want to kind of throw this in here because it is very much part of this equation, and that's the advocacy groups that are fighting for human pain and sleep management. They are out there. Despite the political climate, several professional bodies, they continue to advocate for human pain and sleep management. The Hospice and Palliative Nurses Association is one, and I believe I stated this earlier. It warns of the opioid crisis responsive have compromised pain care. The American Society for Pain Management, their nursing calls for removal of barriers to end-of-life pain relief. Just open the floodgates and give it to them and let it be done. Pain medicine specialists and palliative care physicians argue that comfort is a moral obligation, not a regulatory risk. So if we could get a few of those more palliative care specialists on board with us, we might be able to remodel the system on some level. Outside the clinical world, there are patient advocates and influencers have begun speaking openly about the failures of the pain management system. You can go on any platform, TikTok, Instagram, Facebook, Substack, YouTube, X, Telegraph. There's so many. I mean, I'm sure I missed so many of them. But they talk openly about the failures of the pain management system. There are voices such as Pain Patient Advocate on Twitter, the Chronic Pain Advocacy Alliance. There's National Pain Advocacy Center. Don't Punish the Pain. It's a huge rally. There are legal nonprofits like the Pain Patients Legal Rights Foundation. And they're all pushing for reform. These groups highlight the lived experiences of people who have been denied pain relief. The structural cruelty of the current policies, they are clearly able to articulate this because they've actually gone through the process of it. And the urgent need for balanced opioid regulation. Their advocacy is powerful, but policy has not changed, unfortunately. There's a clinical survey that or a clinical summary that I kind of put together with a couple other people this week. And we just put it out there as what the evidence shows. The evidence is viewed as a whole. A clear pattern, there's a clear pattern that emerges. The opioid war was created, let me start that over. The opioid war has created a system where suffering is not only common, but structurally enforced. Sleep deprivation is treated as a minor inconvenience instead of a severe clinical system. Pain is undertreated because clinicians fear regulatory scrutiny. The dying are denied comfort because the system fears addiction more than it fears cruelty. And last but not least, the evidence shows that the pain management system itself has become dysfunctional, a maze of suspicion, of fear and mistrust that fails more than half of the population and leaves patients feeling criminalized for seeking relief. They feel like a criminal because all they want is relief. Doctors and medical personnel, they're not immune to this harm. Many fear retribution, investigation, and a lot of them will end up losing their license. What was once a calling for many of these people who are in this profession has now become a liability. Their ability to provide humane care has been compromised, and they've been compromised by everything that I have been speaking up here before, by policies that value control over compassion. This is not a war on drugs. This is what I called it in the beginning. This is a war on care. I'm going to wrap it up and I'm going to give you my conclusion. It's been a really good talk for me. I got a lot of stuff out that I wanted to get out to you guys. I wanted to kind of pop with my voice and stuff like that to really get you to understand how the manipulation is, how they lay the foundation and then justify all the pain, all the suffering, and it's just not necessary. So, the conclusion, ending the war on care. The opioid war, from my point of view, has become a war on comfort, a war on sleep, a war on pain relief, a war on the elderly, a war on the chronically ill, a war on the dying. It is a war that fears addiction more than it fears suffering. A war that fears sedation more than it fears despair. A war that fears liability more than it fears cruelty. If we want a humane society, we must stop treating the dying as potential addicts and start treating them as human beings who have lived a lifetime and are now getting ready to leave this place in time. They're going to die. Comfort is not a crime. Sleep is not a threat. And pain relief is not a danger. None of these are red flags. None of these are red signs that say stop. It's time to end the war on care. Bottom line, period. So take what you need, leave the rest. So much love, my friends. I'll see you next time. Be blessed.